Thanks, Isabel. It looks like you've admitted everyone. Is that right?
Everyone's in. She's still
Yes,
just
still working on,
winding up,
getting
making
everyone
people.
ready for roll call, but
Yeah.
I can't seem to get my video going. This is Mary Lou, but that's fine. I'm here. And Isabel, I had a text from Linda Krieger saying that she felt she had signed up to speak but didn't see something, so she wanted to know if she's on something about a vote. So anyway, I don't know if there's a way if you can find out if she registered in time or whatever the deal is.
I will double check that.
Thanks, everyone, for coming this afternoon. I'm Dr. Judy Richardson. I want to welcome you all. I'm one of the two co-chairs of this transition committee. So we'll get going in a moment. When Isabel is ready, we'll take a roll call, take a look at the agenda, and then launch into our meeting. Thank you all for joining us. Are you ready, Isabel, for roll call and tech check?
I am. Okay.
Excellent.
Roll call. Judy Richardson,
Here.
Mike Leahy,
Here.
Mary Lou Henrich. And you mentioned you were here before, but Jensina Hawkins. Didn't see Jensina yet. Charlie Swanson,
Here.
Richard Gibson,
Here.
Antonio German,
Here.
Eve Gray,
Here.
Anne Lovejoy,
Here.
Jamie Osborne.
I see Jamie has a hand up.
Jamie, let me make sure Jamie, there we go, Jamie. You should be able to unmute now.
Yay, I'm here. Thank you.
Thank you, Jamie. Mickey Jerding.
Here.
Thank you, Paula Walden.
Here.
Thanks, everyone.
Thanks everyone for enduring that tech check. Zoom does crazy things, so it's good to make sure that we can all at least hear each other and use any of the technology to participate. Sounds good. Isabel, do you have the agenda on the next slide? We can go over the agenda for this afternoon. We have quite a bit of discussion. If you viewed the agenda and the packet that's on the website, we decided to modify just a little bit and perhaps put off till next time the IT strategy and really focus our discussion today after board updates on the administrative savings, talk a little bit about implementation sequencing, and both of those topics hopefully will have a good discussion and come to some decisions about making a recommendation to the board. We'll wrap up with member reflections and homework for next time and public comment as available. And with that, I'll turn it over to Dr. McDonald for board updates.
All right. Thank you, Co-Chair Richardson. So good afternoon, everyone. This is Dr. Mimi McDonald, Executive Director of the Universal Health Plan Governance Board. Just providing some brief board updates. There was a special board meeting that occurred just this past Tuesday, which was terrific, and went over all the information that came out of the focus groups and the focus group report. That report is posted. So the link is on the website under board meetings, and it's really fascinating kind of how it's been brought together and what different groups of folks around the state think about a universal health plan and specifically different aspects of it. So I really encourage everyone to take a look at that. Coming up next week, very exciting May 21 board meeting. We're having Professor Zhao is going to talk about one of our favorite topics, administrative savings. And also he said he's going to kind of look at it in light of the Milliman report too. So that should be very interesting and coming up. We hope the board will be making a decision on administrative savings, in part informed by the conversation this group is going to have today. So very excited about that. Echo Northwest is going to give will be submitting their final report on the revenue plan. That's not the end of their work. That's just their final report on that plan. And then they're also giving an update on their additional work. It's going to be a basic revenue proposal vote. And then Lee, I feel like I've left something out too. Lee's going to give a final report outline, and we'll also talk about the some of the potential transition strategies. So lots going on in that next board meeting. So next slide. All right, so I am really excited and only a little bit nervous because I'm delighted to let you all know that we have Dr. Jim Kahn, who is a emeritus professor at UCSF. He has 30 years experience in the empirical and modeled assessment of the cost, effects, and cost effectiveness, global health interventions, programs and policies, so much more, so many more accolades and work that he has done, and particularly around, again, our beloved topic of administrative savings. And he is here with us today. As I said, I'm a little bit reticent to go, but he told me I'm just going to do the presentation, and he is here to chime in and to answer questions. So I'm just so great. Jim, you can wave your hand so people can see you.
Thanks for inviting me, Mimi. Someone has to geek out on this stuff, so why not me?
Well, we're just so very, very grateful. Okay, so we're just going to take it away, and I'll go on to the next slide. Oh, there we go. Shout out. I didn't even know he was here before I put that there, so I wasn't sure if he's going to be able to make it. All right, so I want to try and focus our attention on what we hope we can get out of today's meeting. So we hope to agree upon a percentage or a percentage range of total health expenditures that can be reduced by administrative savings, which would occur under the current proposed universal health plan. So in other words, the plan as we know it to be that has been created by this board, and I have some specific information about it, but the rationale behind that this will really inform the revenue target by incorporating those efficiencies that are available with a unified health plan. Now, there's an asterisk there because this is not, what we're talking about today is not the totality of savings that are available under a universal health plan. So it's not including, for example, savings related to prescription drug bulk purchasing, or maybe changes in the way that a PBM operates, or having a single PBM. So we're really focusing, again, on those administrative savings. Now, most of the information comes from studies that we've already talked about or looked at, but what I really wanted to bring forth is a study that Dr. Kahn has worked on and brought forward, which really, to my mind, helps us focus on which parts of those savings are available under Universal Health Plan and how they contribute to the larger scope of savings. So in other words, if you have all of these different pieces in your Universal Health Plan, how will that fit together? So Jim, when I make a mistake, you just please jump right in. So otherwise, we're going to go on to the next slide. And this is Helen Belanca kind of asked me about this. She's like, well, we don't really need to come to a number, do we? Because that's, and I said, well, yes, we do. And I'll kind of try and explain why. So if you look, so this is how the revenue plan and administrative savings come together. If you look at the bottom right-hand corner, in a revenue plan, we would like to be able, of course, the Finance and Revenue Committee and then the board has really worked on this plan and thinking that to raise the revenue, healthcare personal income tax, employer payroll tax, maybe a corporate income tax, corporate activity tax. But what would those percentages be? So somewhere along, if we're going to deal with numbers, we have to deal with numbers. And so that's where we get to. So if you go back to the upper left, I'm just going to walk us through this briefly. If we think about all of the expenditures of a universal health plan, everyone's covered. We have those kind of extra benefits that we've been calling PEB Plus and that expanded population coverage. So that's like the totality of the expenses. But of course, what we want to do is subtract from that and that's from the status quo. What we want to do is subtract from that all the savings that are related under a universal health plan, including administrative savings. I also put down their prescription savings, et cetera. But so that's where we are today, because we need to get there to understand what the expenditures would be under a universal health plan as it's been designed, as we have. Then, of course, you would take away the from that the funds that are going to be coming from the federal government, which we have sort of accounted for. And then that gets us to that replacement target. We need to know what that replacement target is. So then we can translate that via the revenue plan into those percentages. So again, so we're trying to come to we need some sort of numbers here. Again, we know it won't be perfect and things are subject to change, but this is what we're looking for. Next slide. Thank you. So this is something that we have talked about a lot, is that if we look at the whole pie of healthcare expenditures, more or less, in the United States, it appears that about 25% of that is related to administrative costs. So this is, different studies have shown slightly different things, but when we look in the big picture, that's about the size of it. Next slide. So this is where I'm so excited to have Dr. Khan here, because what he looked at under this paper is the administrative efficiency issues, and this is for California's Senate Bill 770. And this report quantifies some of the savings, BIR, we talked about that already, billing and insurance related savings, as a function of the implemented elements. So another, like I talked about, some of those pieces, when you put together your universal health plan, how does that play into it? So when we go on to the next slide, and I apologize because this is going to be small and there isn't a quiz, but what I think is really important is if you look on the far left-hand side, those are all activities that happen on the provider side. So providers' offices, clinician offices and hospitals, they do all of those activities, and all of those billing and insurance related activities essentially take up part of their operating revenue. From all the sources on the right-hand side, you can see it is estimated how much of that, essentially, of their revenue is lost doing those tasks. So again, those administrative that administrative burden that we talk about a lot, and that is on physicians, other types of clinicians and hospitals. Now, of course, there's always going to be a range of numbers, and we know that that different types of clinics have different ranges and different amounts. But again, what this gets to, if you look at the very bottom on the physician offices, so the clinician office side, when you look at the range of it, it's about 9 to 10% of their operating revenue is directly related to billing and insurance related activities. Hospital inpatient side, they are a 10.6% is related, and then 12% admin total. And it looks like Charlie has his hand up. Charlie, fire away.
So as I was reading it, it doesn't look like that's the amount that's spent. It's the savings percentage. Is that correct?
Yeah, potential savings.
Yeah.
Okay.
So,
So yeah. Okay.
so
Thank
yeah,
you.
it's their percentage of operating revenue. Thank you, Charlie, for that clarification. Okay. Moving on. All right, and so this is the part, and again, sorry, because this may be a little bit, take a second to follow, but now we're going to piece together, if you look in the column on the left, it said unified financing options. So let's say, for example, in Oregon, because they're talking about this, like, okay, well, what if we just went with a uniform fee schedule? How would that help? What difference would that make? And you can see by the arrows, and I'm sorry, because it looks like I didn't do a good job on this one particular side, but the number of arrows indicates the impact from there wouldn't be any impact to almost complete elimination of the cost of those things. So as we are going down these lists, so if we think of a first plan, there's only a uniform fee schedule, then B is a uniform fee schedule and completely uniform benefits across the board and completely similar cost sharing across the board. You get down to C, and it's those things plus a single billing portal. So of course, these arrows are going to add up as we go down the line. And then we'll go on to the next slide. All right. So this is when things become more and more fun. So we add on a universal insurance card, or maybe it's an app, get to single formulary. I think it's interesting to notice, of course, because there you've got clinician ambulatory, then you've got inpatient. I'm not really, this particular paper at the portion that is related to the payer side savings is really all comes down under row G, which has to do with no insurer profits and the same benefits, but the rest of it is all on the clinician side. And again, you can see how all of those add up. And what I will say is in the proposal, as it stands now that the board is putting forth and that people have so far agreed on, all of those things that we're looking at are part of this proposal. So in other words, so far anyway, the plan that is being developed looks like it's going to be able to capture all of those types of savings. All right, and I'm going to talk about the medical loss ratio just in the other slide in just a second. So any questions on this? And maybe this was Mike, please.
Sure. Thanks, Mimi. I guess this is a question to Jim. Many years ago, Jim, I used to run Kaiser's hospitals and also had responsibility for their pharmaceuticals. As I look at things today compared to when we were looking at things like this, to what extent can we factor in the incredible changes that have happened because of electronic medical records and AI? And to what extent can we factor in if, in fact, the Universal Health Plan for Oregon would essentially be a monopsony and hence might have higher degrees of control than any individual insurer might have?
Well, that's an excellent question. Of course, the world has changed and is changing rapidly in those regards. I noticed in the latest Kaiser Family Foundation report on the medical loss ratio, or what I call the complement of the medical loss ratio, sort of how much are insurers allocating to their own both profits and administrative functions. And it is actually ooched down a little bit in the past few years, and I assume that has something to do with automation on the insurer side. As for the impact of these kinds of developments on the provider side, I haven't seen any assessment of that, and I certainly haven't done that myself. So I would probably, for your question, note that as an uncertainty. In terms of the monopsony effects of having a single purchaser, I think the state can and should be a purchaser which is seeing simplicity and uniformity as a way to make the entire system function more smoothly. But that said, I am not a monopsony or monopoly economist, and that would be a worthwhile discussion to expand with someone who perhaps could speak to the experience in other countries where, of course, there are many countries with a single purchaser of healthcare. And we could ask for insights from those experiences.
Thank you.
Thanks, Mike, and thank you for that great answer, Jim. Okay, so we're going to go on to the next slide, and which actually, again, I said I was going to talk a little bit about medical loss ratio. So the medical loss ratio, if people aren't always familiar with it, it's this metric that's used in health insurance, which measures the proportion of premium dollars that an insurer spends directly on patient care and related to quality improvement, rather than on their administrative expenses, like marketing and their profits. And so I took the liberty, this is okay, I amended Jim's table a little bit because I just got a little bit more information, again, from KFF just about that. So what this is showing, the CMLR, it's the insurance complement of the medical loss ratio. So let's just say back in the 2016 to 2019, when that National Insurance Commission, that showed that private insurers the insurance complement was 20%. So 20% of the total cost went to their admin and their profit. But if you go over now, so this data comes from 2024 data. As Jim just said, that number's gone down a little bit. So it has gone down in individual and group. And I'll get to your question, Charlie, just after I get through this whole kind of going through the rest of this. I think it's interesting to note Medicaid, that also that medical loss ratio has gone down. And of course, as we know, the price of healthcare has gone up, exceeding than say some of these administrative costs. I will say in Oregon, so OHA in 2022, the medical loss ratio was 87.8. So that's the part that got spent on member services. But in Oregon, 7.5% of the now this is the CCOs in 2022, 7.5% was on admin costs, and they had a 4.7% margin, which is great. So 2022, the CCO's average margin was 4.7%. In 2023 in Oregon, it was 2.2%. In 2024, it was 0.001%. CCOs in Oregon. This is, before that big bill has made any changes. So I think that is something that we have to keep in mind, is that there is the possibility that big profit margin, which obviously if there's a universal health plan, all of that, there isn't going to be any profit, but that profit margin, that difference may not be as substantive as it had been in the past. And again, you can look at Medicare Advantage plans, and again, this is an average, right? So certainly some Medicare Advantage plans still have a high profit margin, but on the average, this is going down. Okay, thank you. And now, Charlie, I'll take your question.
Yeah. So when you say the KFF 2026 information for 2024, was that Oregon specific? Because when I look at the numbers in Oregon, the medical loss ratio is actually a little bit higher, meaning that the overhead costs are a little bit lower in Oregon than the national average, and it's closer to 11% in recent years, from what I can tell. And the Medicaid is actually higher when you count in the overhead that the state has. So I think this is just in the CCOs, but the state also has overhead, and so you really have to add that in as well.
Yeah.
So
just so you know, Charlie, the numbers that are up on the screen right now, those are not Oregon specific. That is national data. But the ones that I was quoting, and I didn't have all of the admin costs. I just had that I was able to get, it's tricky to get all the information out. I just had their operating margin, just showing what I relayed to you all just verbally. But that was Oregon specific. Yeah.
Yeah. So I do have Oregon specific information for medical loss ratios for all of the large insurers in Oregon up through 2024. I can share all that with you.
Oh, yes, that would be great. Make another part of the table. Richard, please.
Is the complement to the medical loss ratio 100 minus the medical loss ratio?
Yes.
But does the medical loss, you talked about patient care, but does it also include administrative services to patients, or you said something about patient services and I wasn't sure. I just want to make sure that we got the nomenclature right.
From the insurer's perspective, it is money spent on care. But you're right that from the provider's perspective, it includes both the resources spent to actually deliver care as well as the provider side BIR.
Right. No, I got that. We'll deal with provider side administrative expenses, but basically it's all patient care from the payer's point of view. So it's 100 minus the MLR. It's a complement MLR. Okay, thank you.
And Charlie, it looks like you have another question. Please.
Yeah. So in Oregon CCOs, what typically gets reported is member service ratio, which is very similar to the medical loss ratio, but it includes expenditures for the patient's benefit that are not medical care. For example, translation services, non-emergency transportation and those sorts of things. And so I think that's probably a little bit more useful for our purposes, but it ends up being about that 9%. I mean, I think that 9% is correct for Oregon CCOs overall for the last 3 or 4 years. But I think we want to keep in mind that, especially for Medicaid, there are member services that are things we want to that our plan is going to cover that are
Right.
not medical care. So yeah.
Yes, absolutely. Thank you. Mary Lou.
I was just going to say, when back in the old days when I started Care Oregon, there was a requirement we could not spend more than 8% on admin, overall admin stuff. And so it was all kind of what you put in that bucket, and you didn't. There was a bit of gaming to make it. And when we were small, it was rather hard at 8%. But as it's gotten larger, it's easier. There is economies to scale kind of thing. But anyway, just it's interesting that we had a requirement that we couldn't spend more than 8%.
Yeah, and there are medical loss ratio requirements for Medicaid and Medicare. Usually, I think I'm trying to remember if it's 85% is the top amount.
I think so. Yeah.
Thank you. Okay, so again, this is just to talk a little bit. So that what I was talking about when I think about MLRs, that's what I'm thinking about, the plan side and where savings are possible, or rather the payer side. All right, so next slide. Okay, I love this slide because I think it does a great job. If you look at the very bottom, you can see lining up all of those provider side savings. And I will say that this money, I apologize because I have an acronym in there. And then I realized I had to look it up myself again. It was the Healthy California for All Commissions. That is what HCAC says. So they came in at 517 billion was the status quo estimate of expenditures. And then what this shows is, again, as you add on all payer rates, same benefits, et cetera, the increasing amount of savings on the provider side. And then column G adds on the savings that would be related to that diminution of the medical loss ratio that could be possible under a single payer. So again, just really kind of lining it up like that. Charlie.
Just to make sure, this is all the provider side savings. Is that correct?
It's all of the provider side savings that I could glean from my understanding and from published studies up through F, and then G includes the payer side settings mainly. The jump there is primarily payer side.
So G includes the payer side.
It's a cumulative.
Yes.
Yes,
Okay.
it's cumulative, and the bar furthest to the right, G, includes both sides.
Okay, thank you.
Yes.
So is that
and
roughly? I'm
Oh,
sorry.
go ahead. No, go
So is
ahead.
that rough? So should I divide, 50 billion by 517 and say it's about 10%? Is that what
That
this
is
is?
essentially correct.
Okay, thank you. Just wanted to make sure I was doing my
No,
math there.
you're
Okay.
you're
All right, thank you.
thanks, Mary Lou. All right, so moving forward, we'll go on to the next slide. How are we doing for time? We're doing okay still. So what I gleaned from this paper, it's a little embarrassing doing it in front of Jim, but the summary was that on the provider side savings, that came to about 4.3% of total healthcare expenditure. So not that the provider side saved 4%, but out of all the total healthcare expenditures, provider side savings reduced the total expenditure by 4.3%. And on the payer side, it was slightly more at 5.3%, coming to, as you very closely alluded to, Mary Lou, a total of 9.6%. So again, and those were the provider side savings related to billing and insurance related administrative burden reduction. The payer side savings, and Jim, correct me, I think I got this right, but is that if would be using an estimate of the Medicare fee for service, their CMLR, if you were able to get to that level, that's the amount of the payer side savings would be realized. And
Exactly.
oh, great, good. And Charlie has
Yeah, so for the provider side savings, that's 4.3% of actual expenditures that would go to payers. So basically would you take away the amount that's for the, I guess, denominator, take away the amount that's spent for both prescription drugs and drugs within provider offices and also for durable equipment, or is it total costs? So I guess maybe what's on the bottom?
So this does not include any savings from negotiating lower drug prices.
Right.
But if I understood your question, these are savings that would be realized on the provider side. And in order for the system to capture that, you would need to have a way to reset payment rates to basically, as a first cut, a blended
Mhm,
current rate that takes into account the mix of payers
mhm.
minus these savings. But also to be clear, that doesn't mean that providers would get less money because utilization would go up, particularly outpatient utilization. And so their total revenue would actually go up a bit, typically,
Yeah.
but their payment per service would need to go down to capture that 4.3%.
And
Yeah, I guess maybe my question to be more specific. So when you're looking at provider side savings, it's 4.3% times the percentage that actually goes to providers and not to other things.
That
So rather than the total healthcare costs.
no, it's
Hospitals
4.
and providers get about 60% of total healthcare expenditure.
Yeah. So I think Mimi stated it right. It's 4.3% of total health expenditures. So it's actually a somewhat larger percent
Okay.
of what the
Okay.
providers are,
Mhm.
because the denominator of the 4.3% includes the payer side. So yeah,
Well, does it include prescription drugs, I guess, and
it
both?
it- it does.
Okay.
Yeah.
That's the biggest question. Yeah. Okay. Thank you. So one other question is, sometimes an advantage of a single payer system is considered to be less moral hazard, I would say. And is there any provider side savings estimate from that reduction in moral hazard that we could have, or is that just something you say it's just better to work in a system like that?
I'm not sure I'm totally getting your question. I'm sorry.
So within the current system, I would say there's a number of providers that would say, because of the way they have to deal with the system, they feel like they sometimes can't make the morally correct decision, or there's a moral hazard in saying, oh, we can't. I'm not quite sure exactly how it goes, but within the provider's minds. But that presumably will be reduced with our system, and therefore you might expect they would say, I don't need quite as much money to make up for that.
Okay, so to be clear, I'm not an ethicist, but it would seem to me that knowing that as a one-time provider, I will say it seems to me that knowing that all of my patients are thoroughly covered for their health care and that I don't need to worry about whether they can pay for care. I don't need to worry about whether they can, which drug they can use because the formulary is simple and comprehensive. All of those things would make me feel better about being a provider in that system. I'm not sure if that's addressing your question.
Yeah, I think it does. Yeah.
So I'd like us to keep moving along. Thank you, Dr. Kahn, for your response. It looks like Richard has one more question, and then let's pitch it back to Mimi to keep going.
Yeah, we've talked about provider administrative savings, but one thing that I don't see in the studies, but I think is significant in real life, is provider collectability of what the patient owes the provider. I mean, there are estimates that it can be 25% of the patient side of what they pay providers that providers don't get paid. So that's not an administrative savings, but when we go to set the rates for providers, I think we need to keep that in mind because there will be no loss of collectability from the UHP on the provider on the patient side paying the provider like there is now. Thank you.
I do not know the answer. If you have a reference on that, please send it to Mimi or directly to me. I would love to learn more about that.
Yeah, actually, Milliman in their report made a comment on that about what their estimates were. So, all right, let's go on to the next slide. We're doing great, people. I'm very, very proud of everyone. All right, so this one, the first several ones are studies that we have already looked at. And again, the way that we're looking at this is this excess administrative spend as a percentage of the total healthcare expenditure. So I'm trying to, at least above the middle blue bar, we're sort of looking at apples to apples. The reason, so the first two studies actually are comparing the US to Canada, just so people kind of get a sense of that. There's an asterisk by the Himmelstein study because if all administrative costs make up 25%, are you saying that all administrative costs could be gone? And the answer is, in that particular study, their conclusion was administrative costs took up 34% of the total healthcare expenditure. So just again, just kind of a sense of like, well, that number doesn't even make any sense at all. So you can see there's a range, and Optimus even in their report. So this is the Optimus report. This isn't what the Joint Task Force went with, but the Optimus report gave that range of 8 to 12%. And then I'm actually, Jim, do you want to talk about the difference between Khan 2010 and then Jawani et al., which you were also an author of, as we look at just at the billing and insurance related only administrative spend?
Sure, the 7.2% comes from my participation in an Institute of Medicine study. And in the subsequent 4 years, Jawani et al. Is from 2014, and I was the senior investigator there. We were able to gather more information and do a refined analysis. So I stand by the 12.4% rather than the 7.2. And if anyone's interested in a technical dissection of the differences, I would be happy to do that.
Okay, so I would like everyone to keep, kind of keep those numbers in your head, because now we are going to go to the next slide, which says, all right, so can we come up with a reasonable estimate for now? The answer is no, that's okay too. And I don't think this committee provides recommendation to the board, so you don't have to make a motion and second and everywhere. This is a little bit more of a gestalt. Mickey, please take your question.
Hi, thank you so much. I wanted to share something, share my thoughts, and I actually put it down so I don't miss anything. And there's a question in here somewhere for everybody. So I want to offer this with a lot of humility because I know there's tremendous expertise around this table, and I may be missing things that are already being considered. And I really appreciate the depth of work that's gone into this. One thing I keep sitting with is whether we're sometimes evaluating parts of this transition through the lens of a mature health system, when in reality, we're talking about designing and launching something entirely new and incredibly complex. So that distinction feels so important because startup phase often requires different kinds of investments and expectations than mature systems do. Things like implementation infrastructure, communications, public trust, provider onboarding, technology systems can sometimes look like administrative overhead on paper, but in an early stage launch, they may actually be foundational to whether the system works in practice. Even newer technologies like AI may actually create efficiencies over time, but they often require meaningful upfront investments in integration, governance, training, oversight before those efficiencies can be realized. And I think the question I keep coming back to is not just what can we reduce, but also what does this system need in order to succeed in its early years? And are we clearly distinguishing between startup costs and long-term operational efficiencies? And last three things. I also want to acknowledge that there's significant operational expertise on this committee, including leaders who've run major healthcare organizations, and I deeply respect that experience. And I think what I'm trying to understand is whether launching a first of its kind public enterprise from the ground up presents different challenges than operating a mature organization, particularly around startup investment, technology infrastructure, communications, and adoptions. And I'd genuinely be interested to hear what others think of in this committee, think about this distinction, especially those who've led large organizations or major transformations. And does this feel meaningfully different to you, or do you think the framework we're using already accounts for that? You know, I'm not raising it as a critique. I think the policy work has been incredibly thoughtful. I just want to surface the question because it feels important to ensure that what we're recommending is not only strong in theory, but durable in practice. And I could see that last thing I'm going to say is that I wonder if we should be looking at this from different stages: early stage, infrastructure enrollment stage, early outcome phase, maturation phase, and long-term stability phase. And there's other things I could say, but we don't have all the time. But thank you so much.
Can I
Nikki,
jump in with a very quick answer, Mimi?
please do.
Yeah, two parts. First of all, you didn't mention this, but I will mention that helping people who lose their jobs, because those BIR numbers are about people doing tasks, they would need to be retrained and maybe retire early. And my colleague Bob Poland at University of Massachusetts Amherst has estimated that that could be done for 1% of the health budget for 3 years. So that would be important to think about in the transition period. The other thing, more generally to your very important point, Taiwan is the best modern example of a shift from a fee-for-service insurance company-based system to a single payer. They did that, I believe it was 1991, so a few years ago. And they probably have experiences on just those issues that you mentioned, and I certainly could reach out, have connections to some of those folks to help answer those questions.
Thank you, Jim. And Mickey, I just so grateful to you for framing it the way that you did. And I think what I appreciate is because, of course, I didn't clarify at the beginning. You are completely correct. Talking about a mature system at this moment, we also absolutely have to have those transitional talks. What we're hoping to do today is, because as you can imagine, even getting to an agreement on sort of like a mature operating plan is a challenge, but we do need to start somewhere. And at this point, because this type of information is around and is accessible, we're working here, and then we'll be kind of moving outward. But your point, absolutely, completely appreciate and nailed it. And I note to self to like make sure that when we talk about this, we talk about it in the way that you said that. So I am going to take a question from Jamie, and then I will then we'll kind of keep going. Jamie.
Thank you, Mickey. You said it better. I was going to say the same thing. And just when I'm looking at your slide here and thinking about conservative, middle of the road, and ambitious, I wonder if it doesn't parallel the savings that we might expect in early development, in middle development, and in mature system. And perhaps we might frame our estimate in that way, because we do expect there to be savings, but it's going to be less initially because we have to invest in infrastructure. And we do expect that to bear more and more fruit the longer that it's there.
Eve.
Yeah, and I think I totally agree with both what Mickey and Jamie said. And I think we have to think of this as being kind of not non-linear in the savings, because I can imagine a mature system where everyone still operates on their own health record being a middle of the road kind of savings. I would imagine that to get to the ambitious level of savings, we need a single communication and documentation platform throughout the entire state, so that there is none of this, like, I can't read somebody else's records. I can't figure out what the patient had done somewhere else. I can't communicate with this platform or that platform. But to get there would be a huge investment. So I think we may get to a point, say we get to middle of the road, I think that would be reasonable for us to think is our target state, unless we want to invest a whole bunch more in additional infrastructure that would allow us to accelerate. So I would think that our goal at the beginning is the middle of the road. And then later on, the universal health plan, the folks who are running it at the time, and the state and providers can work together on how you would take that last road.
I like that. So, like I said, I don't know that it will be that we need to present to the board once, but like, okay, we had a vote and and the number is 9.7 or whatever that is. I don't think so, but I do think I appreciate that. So from what I'm hearing is kind of a little bit of two things that yes, there is an ambitious, a middle of the road, a conservative, and yes, there is also the temporal portion. There's a paper, Jim, that I know that I think you're an author on too, the Kai study, which we've talked about a lot, which I think it showed that, I don't know, out of, now I can't remember if it was like 18 different studies, I think either 16 or 17 of them showed that that there were some savings within the first year of a universal health plan. So it's not like completely unheard of. So there is that potential for early. Am I right on that, Jim? Somewhere around there?
Right idea, wrong numbers. 22 studies. I lived that project for a year. 22 studies, of which 20 showed break even or savings, mostly savings in the first year. And then, as you are implying, over time those savings increased. But that was partly because many of the studies assumed a restricted growth rate. Not so much on operational efficiency, more on just living within a budget.
All right. Mary Lou.
A couple of things, Dr. Khan. I think you probably know that Chun-Wei Chi is on our board, and he was there at the beginning of the Taiwan plan and through, so he's an invaluable resource to us.
Great.
So anyway, that's great. And we do listen to him. The other thing that this is maybe a little off the cuff kind of comment, but kind of maybe I'll just say it anyway, that when we're talking billions of dollars, which this costs are billions, okay? And then we're talking about things like training and IT and whatever, they're big costs, but they're really, in my mind, kind of decimal dust. They are, I mean, we're talking huge amounts. I don't think any of us, and I try to put these numbers in my head and think about them and think, oh, the cost of, and I also have heard that, and I don't know if this is an accurate number or not, but in Oregon, 75% of the health systems and providers are using Epic software. So it seems to me, I keep going, and Washington State is moving on a central Epic kind of move. Mimi explained it to us and gave us an overview. So it just feels like maybe it's some of those costs, although they're big in our minds, because when we think about these kinds of projects, they're big, but related to the billions of dollars that we're spending on healthcare in the toto, they really are rather small costs, which is hard to believe. But you know, when you do the math, it really isn't as big as it sounds to us usually. That's all.
Sorry, just
Yeah,
muted
good thought.
myself. I am going to ask people because my colleague Lee has so much to talk about the transition plan. So if people would like to weigh in, say, yeah, I feel good with going with the middle, please do. Again, I can report all of the sort of summarize the comments that we've gotten from here. I'd love to hear people's thoughts. If you feel comfortable saying a number or a range, great. If you don't, that's okay too. Because I think there's been a really good discussion and still continuing to help frame it. So I will take Jamie first, then Mike. That's the order that I saw it. But we do need to, oh, thank you, Judy. We do need to keep moving along. So Jamie.
I feel comfortable at the middle of the road, and I love 10% because it's a nice round number. My other comment was for us to put on a parking lot is an answer to the question of the moral injury is malpractice reform. So DOD, FQHCs have malpractice modifications that make it less painful for them to receive less money to do their work because they aren't held individually liable. And we might want to consider that similar model because there would be astronomical savings for individual providers who have to pay their own malpractice if they had some sort of malpractice protection because they're participating in a required single payer system.
I love that. Thank you. And I don't know if you saw in the chat, Jamie, Judy Richardson said she's starting a parking lot. Thank you so much for bringing up that topic. I love it. Mike.
Sure. First of all, great comments. I would add for Jim that, we're going to have Bill Shao at our next board meeting. In addition to that, we've been able to get some private funding to get one of our Oregon consultants to look at what is the feasibility of moving toward what's in the slide here, ambitious, 15 to 17%. And actually, we're looking at 15 to 20%. So I will say that that having been a hospital administrator and having been a health plan administrator, I think the tone of my fellow board members should, if we're going to be ambitious with this thing, we have to be especially ambitious in terms of showing that we're not going to have bloated administrative budgets. And I don't want us to be overly cautious because change is hard. I would rather say, I think we'll be a lot more credible in dialogue with providers when we show that we're quite serious about taking, waste out of the system and doing things, like suggesting that there be better malpractice and for insurance for providers and a whole bunch of things, including, clear negotiations with big pharma to reduce things way more than 5 or 10 or 15%. So I'm thinking of this thing not so much as an analytical, are we playing a game of 10% or 15%, as much as I think an emphasis is that we're going to have to focus on rigorously questioning all kinds of expenditures in our current system that we all know really add very little value. So that's my comment.
Thanks, Mike. You going to give me a number?
I think it's somewhere between the middle of the road and ambitious. I definitely agree that it needs to be. It's going to be ramped up over perhaps 3 years. That's my perspective. I'd like to aim for 15%, and I'd like to start in the middle of the road. But even that might be a little bit ambitious. So I think we need to think about this some more.
Thank you. All right, I'm just going to see if there's anyone else. Got to make sure if I don't see any other hands up. No, Judy Richardson had kind of weighed in on a middle of the road. You all can email me or send me your thoughts later. Anne, I see your hand up.
Yeah, I'm in favor of middle of the road, and I kind of agree with Mike. We could do 9 to 12%. The other thing I'd like to put on the parking lot is some of the licensing folks from the state agencies are telling me licensing has some integrity problems. So if we're going to reform malpractice, we also have to tighten up some of the credentialing standards.
I like that. Thank you. All right, I am going to stop now.
Tony's got his hand up.
Oh gosh, I didn't see that. Sorry, Tony.
Oh, no, that's all good. It's all good. Thank you, Mimi. Thank you, Dr. Khan. This is incredibly helpful and instructive. I'll just put a number for you just to the process here. I'm middle of the road. However, I just think there are, such a great deal of studies and things have changed over the last 10 years. And we've looked at the review, the comprehensive, there are multiple studies going on with this, since the early 2000s that are in front of us. And Dr. Khan, I just had a question to follow up. Each state is different. And I am curious about the process that you took with California and what it would take to be more specific. When we are talking of billions of dollars and putting forth a budget, it would be most ideal to kind of be able to do that review. And I know we have some other colleagues that are going to be contributing it. One of my past instructors, Bill Shao, is going to be weighing in on this. There are a multitude of people, and I think having a lot of great minds weighing on this question of what is the budget that we need to put in place for those next steps for the revenue creation. This is something that we've been wanting for over a year, and we're here. And the rubber's meeting the road, and we're putting down some estimates, and I am there. But are there other, what process did California go through to do this review to inform them in their process? And how can we accomplish that here in Oregon?
So, great question. I was not directly involved in the California process, but from my familiarity with the evidence on the potential savings, it is not done in a way where we can relate the savings to the particulars of specific states. There are studies that are done at the investigator's home institution. There are other studies done with national data sets. It's kind of all over the place. And to my knowledge, no one has ever gone through and said how much of this is California specific, how much of it's Oregon specific. I think the California report, I think, reasonably reflected the general state of understanding of how much could be saved, some of which, of course, I contributed to. And so I thought they did a good job. And I haven't heard anyone saying, is this specific to California? Because some of the research was done in California. So maybe it's a little bit more relevant. As far as I know, none of the studies that I can recall right now were done in Oregon specifically. So I think the idea of having initially a qualitative discussion, are there things different about Oregon, like maybe the size of medical practices might be an issue, or the number of private insurers and private health plans, the more, not the merrier, can be very burdensome. So I think those kinds of qualitative discussions might lead to some potential to modify the estimates to Oregon. But as you can see, there's considerable uncertainty even within each of these three columns. And I would be surprised if we came out of an exercise like that confident that we could understand how Oregon differed from the generic estimates. I could be wrong.
Thank you for that. Really appreciate that and your candidness on that. I think I'll just add to my comments and leaning towards more of our ambitious goals is that when I look at the total administration that takes place in sectors like Taiwan, and something that I think we're really leaning towards, when we look at total share of administration, it's 2 to 5%, and So I think we are being ambitious. I think we need to be honest with the constructs that we're putting in place, and the simplicity that we really need to lean on. So thank you.
Right. Thank you, everyone, again, so much. I am incredibly grateful. Dr. Khan, thank you so much. Just delighted to have you here. And I am grateful to all you amazing committee people for your deep thoughts on this and your incredible conversation. I am now going to turn it over to Senior Policy Advisor Lee Hastings. So keep your brains going, people, because
Mimi,
we've got more.
do you want me to stay on or jump off?
Well, you are welcome to stay on or jump off, whatever you like. So I think we're wound it up for here. We have like 30 more minutes.
Well,
Lee's presentation is really good, though.
if you don't mind my staying on, I will. And I just want to also thank everyone for letting me participate. I've learned a lot today. You guys have an incredible group here.
Thanks, Dr. Khan. We welcome any bit of jumping in on this. We know you've been at this a while, so help us out here.
Right, with that, we will move to implementation sequencing. I know that took a lot of brain power. I know it did for me just to follow the rich discussion. So if you want to do a little quick stretch, take a second, and let's dive in. Next slide, please. All right, so just to set us up for what we are here to discuss and hopefully decide, we're looking to identify a preferred sequencing option or maybe a couple options to recommend to the board. So this doesn't have to be super specific, but we have some broad categories, and we're hoping that we can kind of focus around ideally one of those, but even two of those would be helpful. So what's on the table? We talked about a few last time, and the ones that sort of rose to the top there was a Big Bang implementation and a population phase-in. And today I'm also presenting kind of a hybrid approach between those. What's out? There's pretty clear consensus around removing the service phase-in idea, so that is not something that we are going to be discussing today. Next slide, please. Just some context, everyone's aware of this, but I've just been noticing in general news a lot more stories about it. So I figured, worth kind of reminding us all why we're here, why this idea of putting together a universal health plan is so important. We're talking about getting coverage to millions of Americans that have been impacted by HR 1. We're talking about the uninsured. We're talking about, healthcare costs that are increasing faster than wages, et cetera. Next slide, please. So let's dive into our options and leave lots of time for rich discussion. That first one is the Big Bang. As an overview, under this implementation model, all major coverage populations would transition simultaneously into a universal health plan. So essentially waiting until every single set of approvals was in order and then kind of flipping the switch all at once. This does require, of course, extensive alignment of the state programs, employer-sponsored insurance, and federal programs to the extent that we are able to secure those. So advantages, of course, this means that when you do flip that switch, you're about as close to single payer as you might be able to get, which I know carries a lot of advantages that we've seen in other nations that are able to achieve a pure single payer. There is also opportunity for that maximum administrative simplification because you are achieving that maximum consolidation. However, this pathway does contain a number of risks that are important to consider. It's dependent on multiple federal approvals, including certain federal approvals that we don't know that we can get because there actually is no pathway for it. And that's a really important consideration in this option. It's also a very extended and dependent timeline. So again, if you're waiting to flip that switch, it means you are waiting on an outside party, the federal government in this case, and the federal government is under no obligation to negotiate with states. So there is a fair amount of dependency that is embedded in this approach. It is also the most complex operationally in terms of you have to be prepared to handle the entire state population, more or less, on that day one. So not a lot of time for ramp up and definitely the longest timeline. Next slide, please. We also discussed last time the population phase-in, and under this approach, the Universal Health Plan would launch with a subset of populations and then grow over time. And what we've presented here is one model of how this could work, outlined in 3 different phases. So under what we have proposed as a population phase-in model, phase 1 would consist of all those non-federal populations. So essentially the populations that the state could loop in without needing outside approval. So they could pass legislation and they could get started working on this. So that of course would be those state employees under PEB and OEB, non-subsidized marketplace folks, employer-sponsored insurance, and the uninsured would all be included. And collectively, this accounts for about 55% of Oregon residents. Phase 2 would consist of those that have federal waiver pathways. So we're talking the Medicaid and CHIP population, as well as the subsidized marketplace folks. Bringing in that group of populations would bring the total to 82% of Oregon residents. And Charlie, I'll get to you as soon as I walk through this. Phase 3 would be incorporating those federal populations for which there is not currently a pathway. These are the ones that are expected to take the longest because there's the possibility it would actually require new federal legislation. And I don't know about the rest of you, but I don't necessarily trust our federal government to move very quickly on things like that. So this would be leaving those populations until pathways are both established and we can get approval. And that would, of course, get us to 99% of Oregon residents. Charlie.
So I have a couple of comments. The first one is related to Medicare being in phase 3. I think we still seem to be forgetting that in many people's minds, there is a pathway for Medicare, and that is for the state to become a certified Medicare Advantage insurer. And so I think we need to keep that in mind so it's actually more in phase 2 than phase 3 in my mind. The other thing I would say is for risks, I don't understand how you could do phase 1 without increased taxes. And if you do that, I don't quite understand how you would justify doing that when you're taxing everybody, when you're not including everybody. So I'm not quite sure how you would design a tax system that could do what you want to do and be considered fair by those that are not being included. So I really don't quite, maybe there's a way, but I don't understand it yet. So I'll stop there.
Yeah, and I appreciate the comments there. So I'll just note that creating a Medicare Advantage plan is an option. It does not mean that Medicare is something that the state now has control over that population. So simply because the state has its own Medicare Advantage plan, it's not able to mandate that all Oregonians that are Medicare eligible are in that plan. So what you've actually done is you've created another player in that field. You still have folks in Oregon that are on Medicare fee-for-service, as well as folks that can do other Medicare Advantage plans. So it's a possibility, yes. Does it actually get the Medicare population in? Not really. And then as far as the financing of it, that is definitely something that we will be talking about in the future. I know that other states that have proposed plans, such as Vermont, had proposals whereby the taxes that were imposed to pay for the healthcare financing would not apply to Medicare eligible folks, precisely for the reasons you articulated, not wanting to tax them while they were not receiving the benefits. Eve.
Yeah, I would agree with either that option or some sort of a tax benefit for your out-of-pocket expenses in Medicare, for example. So you could, if you submitted proof of out-of-pocket expenses associated with your health plan, that would be recognized on your taxes and you would see a discount, which would actually then give someone some sort of a benefit to where hopefully we reduce their out-of-pocket contributions during a time of life where the utilization of healthcare tends to be pretty high.
Thank you for that. Here we go. Mary Lou.
I was just going to say, Eve, that Oregon already does give folks that are on Social Security, Medicare, a $1,000 deduction for each person. So a couple would have a 2,000 deduction already. So if it was, major out of pocket, definitely it would help. But it would be, I think, only kind of marginal. The thing that if you could go back to the slide before, Lee, I'm sorry. Okay, down on the risks, I think that operational complexity of not going with the big bang is actually more. That with kind of all of these various, ways that you're getting paid, if you're a provider, with the fact that you have people in and out of these, systems, et cetera. I'm just almost thinking that from my mind, unless I'm not understanding what you're meaning, that operational complexity, at least from a provider end, would be more, rather than the other way.
Yeah, and that's on me. Here I actually mean the complexity of the public corporation on their side setting everything up. You're
Oh,
absolutely
okay.
correct, though. The administrative simplification would be maximized under this model.
Okay, thank you.
All right, any more comments on either of these? All right, let's jump forward then. So another option that I wanted to present for folks was a hybrid Big Bang-ish or Big Bang light, if you will. This is essentially looking at that population model, but starting with phase 2. So this would be starting with all those populations that basically have a pathway towards inclusion. So the non-federal, as well as the Medicaid and those ACA subsidy folks. So this would launch with all those populations that we know how to include them, we know what those steps are, and we can map out that timeline with a little more precision than if we're including folks where there is no particular pathway. So of course, advantages, this is really kind of, it is the hybrid. It is partway between the advantages and disadvantages of each of the previous two models. It's closer to that single payer. It allows for some meaningful payment adjustment as well, because we are bringing that Medicaid population in to start with. Risks, there is still some federal dependency, although as I mentioned, Medicaid negotiations, because that's designed as a partnership program, that's something where we have slightly more certainty around it, although it's not quite as precise, and that partial complexity still does persist to some extent. Mike.
Yeah, I actually have a comment but question to Richard and Charlie, and maybe Jim if he's still on. So if we take your option, what if we were thinking of normalization? Because as I begin to think about that, and certainly based on some of my conversations with Charlie, it may make some sense to consider 1 and 2 together as a start. So maybe it's a little bang but I think all these things are significant changes. Because if we only start with one piece without the normalization, including Medicaid, then we give up on all the potential financial benefits for the state. So it's just something to think about. Combining 1 and 2.
Thank you for that, Charlie.
So one of the things that I don't quite understand is, in my mind, you don't get any of the provider office savings until you're almost completely Big Bang-ish. And so with the option, when you're phasing in, it's like it's just more expensive. Or I'm not quite sure what that phase in buys you for that short term, because you're not getting any of that provider office savings, and therefore, and you're not getting any of especially the hospital savings, because you can't do a global budget for hospitals. So you still have all of the expenditures for individual billing that you currently have in a hospital. And so it just seemed, I don't quite see what you're gaining by putting, doing like the phase 1 part. And then I also want to say that, and this I brought up last time, is there another thing that we should be thinking about is for the Big Bang, in order to get ready for the Big Bang, there are a lot of things that we should do, in my mind, that would help in the short term to some extent, and would also give the state practice in doing some things. And so it's to me, the hybrid Big Bang that I want to consider is maybe a slightly different notion of a hybrid. It's like a preparatory step to Big Bang model. So I'll stop there.
Right. And I know some folks have their hand up. I wonder, would you all be okay if I went to the next slide just because it directly addresses Charlie's question? So I do just want to touch on this. Administrative simplification came up a number of times, so I wanted to really specifically dive into that. When we're talking about provider, administrative burden, et cetera, we're talking about the number of different plan configurations. And so this is something that I wanted to look into very specifically. So breaking down those different types of coverage, these are all estimates. That's why there are ranges provided, but I can tell you that this is less than the number of actual plans that exist under each of these. So it's an estimate of the number of plan configurations, which is sort of a combination of the payer, the network, the billing rules, prior authorization requirements, et cetera. Now, what really jumps out here is that if we're talking about fragmentation and plan configurations, the vast majority of that is in employer-sponsored insurance. And that's because that's where we have ERISA plans, and that's where we have the highest degree of customization. And there is no question that that segment is orders of magnitude more fragmented than any single other payer source. So for that reason, if we look on the right at the percent of simplification for providers, that non-federal population, which is about 55% of residents, accounts for about 85 to 90% of the variation that providers deal with in healthcare plans today. That's 85 to 90% just from that phase 1 group. When we go to phase 2, Medicaid and ACA, it's a small bump, about 91 to 94%. And when we add Medicare, we get to about 98% of that simplification achieved. So that's reducing the number of different plan configurations that we're asking providers to manage. All right, Richard.
I was going to say in response to Mike's question, phase 1 and phase 2 is what I thought the hybrid was. Mike was asking about.
Yes, that's correct.
That's what hybrid is, Mike. Thank you.
All right, Eve.
I certainly agree that any kind of standardization is helpful in creating administrative simplification. I think the other thing that we really have to look at is the cliff that's being created with HR 1, the number of individuals who will become uninsured, and the pool of folks who will no longer be paying their medical bills and how that will impact provider groups as well. And that's why I do feel like the sooner we can get going on the groups that are most going to be at risk of medical bankruptcy as the rates of healthcare continue to increase, as we are facing a wave of individuals who are uninsured, we do a lot of benefit to our community. And I think it will be interesting to see what the recommendations are coming out of the Medicaid Reform Advisory Group. I understand those will be available hopefully end of next month. And I have heard from a very good source that changing the CCO model will be on the list. And I think if that's something that the governor is interested in seriously considering, and I don't know whether that will be true, it might be easier to pull Medicaid into that phase 1. I think that if that is not under consideration for the Medicaid redesign, it will be harder to get that to happen. So it might just depend upon how those recommendations come and whether the universal health plans, that public entities' ability to pick up that happens at a kind of fortuitous time with those recommendations. And my apologies, I will need to step off in 5 minutes, but I will watch the last 5 minutes of the meeting.
Thank you for that comment. Jim?
This is a very interesting set of considerations, strategic and so on. My guess is that the realized savings, might not be quite as high because of the residual complexity of the unincorporated components, but I think the psychological perception may be really important if people who are incorporated into an initial phase are experienced by provider offices as just much easier to deal with because of their uniformity within that large group, and just because the state is a good payer. That could probably go a long way toward further building support for the rest of the changes. And even though, in my view, we're not looking at an administration in Washington which is going to accommodate this kind of thing. With the next administration, hopefully there will be more openness, and the greater the enthusiasm and support for the initial phase, I think that is a non-trivial bonus in the ability to go all the way to a fully simplified system.
Thank you. And I think Judy was next, and then Charlie.
Thank you. I just want to be mindful of the time and bring the committee back to the high level broad brushstrokes. I'm a generalist, so I'm going to pitch it back this way instead of getting stuck into the weeds. I think what the board needs to hear from us is that there's consideration of a phased implementation or there's not. And so I'm hearing general consensus about a phased implementation, either the mostly hybrid model, but that's what it's sounding like in this conversation, with the caveats and the explanation to the board that there are risks and benefits of doing that.
Great. And can we just go to the next slide just for people to look at? We'll continue the conversation now. Charlie?
Yeah, so the related to the simplifications that would occur by bringing in, I guess, the employer-sponsored insurance. About half of the employer-sponsored insurance is through self-insured, and I don't think this. I mean, we said the state had control over it. I don't think the state does have control over that. We can offer it, but those insurers, we could not say to them, you can't do that. So I think it's really more like about 25%, maybe 30% of the population, if we just bring in the ones that we do have control over within the phase one part. And if you bring in phase two, it gets quite a bit more. But I think the numbers seem to overestimate the population we have control over. So.
All right, thank you, Jamie.
I just wanted to ask for rebuttals for my comment in the chat. The big bang would become the small bang if the federal waivers don't come through. But is there a bad reason to request a small bang just because, like if we request from the feds expecting them not to cooperate, and here's our kind of watered down plan of what we're going to do because you're obstreperous, I don't see them feeling motivated to line up behind us. Whereas if we say, look, we're all in, you have to get behind this with us, it feels a little bit more psychologically compelling. And the reality may be we end up with the small bang because they won't play. But I'm not sure we should ask for the small bang because of that. But I'd love to hear if somebody sees it a different direction than I.
I can just offer, having spent a lot of time today looking at Vermont, that I think the risk is more the extent to which your financing starts to become dependent on getting the federal money, which was part of Vermont's challenge. All right, chairs, I do want to be cognizant of time. I know we want to maybe leave some public comment. It seems we have Tony and Mary Lou. Can we move forward one slide as well, just to the final comparison thing? Tony.
Thanks, Lee. This is great. Good work. I am in line with what Jamie's thoughts are. I think there are a multitude of reasons and trade-offs and concerns. with leaning on the hybrid that leads to more complexity, does not necessarily demonstrate the provider side savings and the administrative simplicity that we're trying to hope to accomplish. I also just grow very worried in a state that is highly dependent on Medicaid and seeing a ton of clinic closures and hospital closures because we are dependent on that, and that is not keeping it afloat. And so we will see more closures. I know we're concerned about the uninsured and with that. But I also think that the politics of coming in, this is strong, like this is what we want. So what I would recommend for the governance board is to put that, yeah, we want this being top one. If we can't get that, then we would recommend number 2 to go with a hybrid. But I've been leaning more and more and hearing that. And just a comment on the price normalization and some steps that I think we can do. I think we're going to see some interesting things coming out of the Medicare advisory group and some considerations in this legislation that will set the stage for some price normalization and some further controls on our spending as a state. So just some ideas with that.
All right, well, here's our final comparison of options. This really just summarizes all of that, but I will turn it over to the chairs to see if we want to do any kind of formal decision.
Well, for staff and to Mimi, do you feel that you can consolidate this conversation in a way that provides the board with some meaningful input?
I do. I think that we should be able to do that. So I don't know, again, sort of like our other conversation, I don't know that we need a vote, but I think we'd be able to express kind of all the sort of the preponderance of opinions and the diversity of opinions.
Mm-hmm. Thank you very much. And I think underlying that is the thought and the contributions that have supported the different ideas and explanations, because the board may come up with something else entirely. Thank you. Do we have public comment today?
Yes, we do. We have 2 members of the public signed up to share public comment with us today. As always, we really appreciate people sharing public comment. If you have comments to share in these meetings, you can submit written public comment via our website, and the deadline for that is 72 hours in advance of a meeting. And for oral public comment, like we're about to do now, you can sign up 24 hours in advance of a meeting. So everyone will have about 2 minutes to share your comment. We'll display a timer on the screen, and if you give me just a moment, Lou, you will be going first, and I will got a couple clicks here, and you should be able to unmute and share your public comment now.
Yeah, hi. Thank goodness that we're finally getting into the savings part of our plan. I really appreciate the work that's gone into this, and I somewhat would favor a little bit more detail, and where would the savings be on denials? No more denials, no more paperwork, etc. But I won't go on with that. The one thing that I have not heard from the transition group is, how do you expect the insurance companies to respond? If you go into a transition period, how will they respond? And my hunch is that they will do everything possible, whatever point of contact they have with the plan or away from the plan, they will use it to destroy the plan. You're talking about millions of dollars. This is, and you're talking about the first state in the union to do this. It's going to pour a lot of money into making sure that this thing does not succeed. So with that said, I also wanted to say, which I would support the Big Bang then. The timing that we're going to place for this, I think you need to consider 2028 as the timing for, or 29 as the timing for federal waivers and whatnot, in hopes that the administration will substantially change and be more open to this program. Thank you.
Thank you, Lou. And next up, we will have Linda. If you give me just a second, you should be able to unmute and share your comment now.
Thank you. So I just wanted to comment on the comparison of options slide primarily, and I appreciate and agree with a lot of the comments, especially Charlie's comments about the hybrid. I was expecting the hybrid based on the last meeting to be more of what Charlie talked about, which is really it's proposing the Big Bang, but with interim steps as proofs of concept that wouldn't require outside approvals. But the other thing is that I question, and I was hoping maybe throughout the meeting we'd get a little bit more information about this, but the time to launch. So it seems to me like the time to launch for Big Bang is shown as 6 to 10 years. For the population phase in is 1 to 2 years, and the hybrid is 2 to 5 years. And I assume that's to start the launch. I guess I'm really questioning the Big Bang 6 to 10 years especially, and I would encourage the committee to think about that. And then I agree with some of the comments about the populations being covered independently, about whether that would actually provide the amount of savings that we're hoping for on the provider side, given, yes, it would reduce the number, but I'm not sure that reducing the number gets at the savings. I think you have to go to single payer to really get the savings. So I don't think it's a linear. I don't think reducing it 80%, the complexity 80% reduces or gives you 80% of the savings. I think it's very different from that. So those are some things that I thought about as I was looking at this comparison of the options.
Thank you. And I think that's the end of our public comment. Isabel, thank you very much. I want to thank everyone on the committee for your time and thought. For our special guest speaker, Dr. Khan, thank you for your time and your expertise as well. To the entire committee, I would encourage you to listen in or attend the board meeting next week on Thursday, the 21st, beginning at 9 a.m. in Salem. This transition committee and the board have worked so that there's some synergy. They will be hearing summaries of our comments and discussion today, and may be tasking us with new homework next week. Anything else to add, Dr. McDonald?
No, thank you. Just again, gratitude to all the committee members, Dr. Khan, and all the rest of my staff who have done a tremendous job. So I'm very grateful.
Great job hanging in there, everyone. We're adjourned.